So, case presentation. What's working and what's not? That's the title of this conversation, what's working and what's not. And the answer is that what is working is that patients like their doctors, they trust us, and they're willing to accept low-fee cases, meaning the type of fees for procedures we typically do on a single tooth. What's not working? What's not working is that we're not successfully presenting the cases that involve multiple teeth, comprehensive dentistry, and elective dentistry. Now, I could sit here in this conversation and talk on and on about why we're not presenting these, but the main answer is we're not diagnosing them. So the first point is that every patient needs to have a complete comprehensive diagnosis using something that we call at Levine Group the 5-phase exam. That's a trademark name for a method that we use to absolutely ensure that every patient is completely diagnosed. Because what I have learned, and I'm a general dentist, so I understand this, and I'm not being critical, I'm not judging, we're consultants. We don't criticize, we don't judge. What we do is look for opportunity. And the opportunity here is to do comprehensive diagnosis. So we teach a concept, as I mentioned, called the 5-phase exam. There are 5 phases in the exam: the periodontal exam, the tooth-by-tooth exam, the cosmetic exam, the implant exam, and the occlusal exam. Now, you might say, well, I'm doing that now. What you're not doing is breaking this up into 5 separate phases, all in one appointment, explaining to the patient that you're going to do a 5-phase exam and what that entails, having separate scripting for each phase. Scripting is the most important training tool we put together for the doctors and the team. And as a world leader in creating scripting in dental consulting programs, I can tell you the difference is that right now you're communicating, but our value creation scripting is about influencing. Why should the patient say yes? So, phase 1, the periodontal exam. 71% of offices do not probe and record pocket depths even once a year. That means we are not diagnosing the single biggest epidemic in dentistry, possibly the single biggest epidemic in healthcare. I have heard, I can't prove this, that periodontal disease is right up there with the common cold. If it's that pervasive and we want more to do in our practice, we want to help our patients, we want to provide quality and increase production, they all go together well, then we need to probe and record once a year. When we find periodontal disease, we want our targets. Levine Group does everything by targets. We want 40% of your active patients in general practice to undergo initial therapy and 60% of your new patients. Once you're done, those that are able to stay in a routine periodontal maintenance program, that's great. Those that need referral to periodontists, that's great as well. And the periodontist will alternate with the general dentist, so you'll still have 2 hygiene patients a year minimally from that patient, 2 hygiene visits. That's the first phase. We explain periodontal disease, we diagnose it, we explain our findings. We don't present the case at this point. Second phase is the tooth-by-tooth exam. That's what dentists are really good at, is looking at teeth, finding anything wrong, and deciding whether it needs to be fixed or not be fixed, treated or not treated. I will comment that many dentists wait until something is really wrong to take action to fix a tooth, when we probably should be a little more preventive, but that's an individual choice. Third phase is the cosmetic exam. A cosmetic exam is based on comparison. Adults learn by comparison. You hand the patient a large hand mirror, you take out a shade guide, and you score every anterior tooth against the shade guide. Within moments, patients will be asking you, what can we do about this? How do I make my teeth whiter? We have whitening, we have veneers, we have crown and bridge, we have composite, we have orthodontics for straighter teeth. We've got lots of options that we're never talking to the patient about because we're not hitting that level of diagnosis. The fourth phase is the implant exam. Remember, each phase has an introductory script so the patient feels full value here. And the implant exam is rather easy. I talk about this in all of my general dental seminars because implants are a rapidly growing field. It's very important. They're a tremendous production center for the practice, and yet 60% of general dentists do not restore an implant case in a 12-month period of time. So what we do is we look for a missing tooth. We look for a space. If it's missing, it's probably an implant case. And finally, the fifth phase is the occlusal exam, where we actually mark the teeth, we do analysis, we look for interferences. I agree, not every malocclusion needs to be repaired, not every interference needs to be equilibrated, but many do. And there's a wonderful opportunity that's going to grow in the area of occlusion that's barely been touched by our profession. So based on all those parameters, the 5-phase exam, we come out with recommended treatment. Now, should we tell the patient at that visit exactly what we found? And Julia is a woman I met recently at one of my seminars that I was presenting, and she is now a client, and she is not doing very well with case presentation. And she said she can't believe how many patients come in, she does diagnosis, she presents treatment, and she never hears from them again. Well, there are a lot of factors there I will talk about in other conversations with Roger on the Levin Group website under the Resource Center section. But it's very important to understand that Julia was finding dentistry and presenting all of it to patients at the same first visit. Our rule of thumb is that if the treatment plan is going to be over about $1,000 or $1,200, you're better off bringing the patient back. Otherwise, it's what I call too much, too fast. They just met you, it's too much to hear, so instead let them come back. It's a totally different relationship when they come back, especially if you follow all the steps I'll be talking about in other conversations. And when they come back, they're more trusting, they're more comfortable, they're more open, and you're more likely to hear the word yes. So I hope you've enjoyed this conversation about the 5-phase exam. The end point is always present ideal treatment. Just don't present it too fast. On behalf of myself and all of the consultants at Levin Group, I thank you for joining me for this conversation with Roger.